I know that one opportunity of this meeting is to network, but I'm going to ask you to now take your seats for our next speaker. Thank you very much. Our next presenter is Dr. Sean Boynes. Dr. Boynes is a dentist anesthesiologist. He received his DMD from the University of Pittsburgh and completed a 3-year residency in anesthesiology at the University of Pittsburgh Medical Center. He currently serves as the executive director of Person-Centered Care for the partnership of DentaQuest Partnership for Oral Health Advancement. At DentaQuest, he oversees national programs and initiatives focused on the integration and coordination of care. Prior to his current position, Dr. Boynes was the director of dental medicine at a federally qualified health center and served as the director of anesthesia and pharmacological research at the University of Pittsburgh School of Dental Medicine. A prolific author and speaker, Dr. Boynes has been recognized by several organizations for his work in health policy and clinical care. Dr. Boynes will speak today about integration, oral health, and interprofessional practice. Following his presentation, there'll be a short, brief Q&A session, and then Dr. Boynes will facilitate the discussion section, Planning for the Future Landscape of Oral Health, where we will engage in a gap analysis strategic planning session. So please join me in welcoming Dr. Sean Boynes.
Hey, how's everybody doing? All right. So, Jack, I am going to do a stage dive in about 20 minutes, and I'm expecting you to catch me, okay? All right, so thank you all for being here and allowing me to talk about something near and dear to my heart, oral health integration and interprofessional practice. I will preface it this way by saying you're going to hear me say we and us a lot. The we and us is the multitude of partners that helped put a lot of this knowledge I'm going to share with you together. Actually, when I look out, about half of you are responsible for most of the slides that I have up here, and I will try to give you credit where credit is due when I can. The DentaQuest team is sitting right back here. I will tell you, if you think I look good, it's because of them, and if you think I look bad, it's because of me, because they do a great job of making sure I do not look stupid when I stand up here in front of you. I also want to just do a quick level set. I don't know if you're aware of this, but last time we looked, there were 139 definitions for integration in medicine. All of them actually make sense to me. It depends on where you're at in your silo, and it works. So I wanted to say integration to me is getting two systems to work together. And interprofessional practice, I'm not saying this is the definition that you have to use. I'm not saying this is the right definition. I'm saying here's our definition, so when you hear me say it, you know what we're talking about. So interprofessional practice to us is a tool that allows for integration to happen. And under the umbrella of interprofessional practice is the integration of care and the coordination of care. You need both to work. The truth is, it's really easy and really affordable to do the integration of care, and really expensive and unbelievably difficult to coordinate care. The two pieces I will point out as areas where we continue to struggle with oral health are at the bottom middle of that screen, which is risk stratified care and understanding that in a population health context, and patient engagement, real patient engagement that actually motivates individuals to care. So now that I level set, I have a great quote here from Don Berwick. I think everybody knows Don or Dr. Berwick, depending on what room you're in. And he says, healthcare is an exercise in interdependency, not personal, I'm going to say heroism, because in my young West Virginia education, that is exactly how we were taught to say it. And a need for a greater teamwork to ask, what am I part of? I'm going to show you a couple of slides, and I'm going to single out that last piece, because there's different ways you can ask, what am I part of? So the first way to ask is, man, what am I part of? And we are part of one of the worst healthcare systems in the free world. This was done by Eric Schneider, a Commonwealth Fund. Sorry, it looks like Don Berwick. I'm giving him extra credit just because I like him, but this is something that the Commonwealth Fund did. And really, they looked at healthcare spending and system performance. There were lots of things that went into this. Dental was one. Unfortunately, as my predecessor said, there's only 14 metrics, so it didn't have as much of an impact. But as you can see, we really pay a lot for lousy care. And from the peanut gallery, it's consistent, if you did not hear. And please heckle me as much as you like. I was sharing earlier, so I consider myself a musician. I think other people do not, but I try to. I used to be in a little rock band, and we did a gig in Parkersburg, West Virginia. And it ended up being a biker bar. How many of you seen the Blues Brothers? I literally lived that. And so after that, it was kind of all downhill. So heckle me as much as you want. I appreciate it. So then we can go to, okay, what am I part of? So this is Neil Howphones Work. Dr. Howphone is a pediatrician by trade, a policy guru during the day. And really what he established was there's 3 areas of healthcare. What I would like to focus on is sort of that third era, the 3.0 era, which is really where we're trying to get to. Now, truth be told, more of medicine is sitting in that 2.0 era. I know many of you will realize that dentistry is still in the first era. So we have some work to do. But for me, the reason that Dr. Howphone's work was very influential in the way we started moving forward with the things we did was because it made sense to me from a couple of different perspectives. One, the goals of the health system are no longer into reducing disability, but into optimizing health. And the model of health is a life course health evaluation, not here's that thing you need in acute care. Our chronic care in medicine, from my perspective, still has a lot of acute care to it. So how do we take a step back and understand how we're affecting the life and what that patient is going to undergo from that time forward? And then down to the bottom of that in the 3.0 era, the role of the health system and the provider is to optimize health and well-being, no longer to prevent and control risk. So no longer perpetuating a surgical intervention system trying to prevent that from being needed. And most importantly, the most important piece I can get from this is that last one, which is we're seeing that people want to be co-designers in their health. They want to be able to have more input, to not sit and be told exactly what they need from someone they only see 2 hours a year. And now I can say, what are we part of? So this is from Dr. Berwick. He gave this particular slide and presented on it at the National Organization of State Offices of Rural Health. And he really kind of simplifies Dr. Howphone's work, which is we're going from a fragmented payment system to a unified budget, hospital as a center to home as a hub. I agree with my predecessor that home is one of those things that's tough to get away from as a brick and mortar. From excellent soloists to high-performing teams, from moving people to moving knowledge, but most importantly, what is the matter with you to what matters to you? And I will tell you, as you hear about the DentaQuest partnership for oral health advancement, you hear about person-centered care from us, that is paramount to me and to us, is what matters to you. Because if I can't figure that piece out, I don't know if I'm going to be able to make you healthy. So let's talk about oral health and a healthy life. Lots of correlations going on between oral health and systemic health. And we are at a point in dentistry where there is sort of this pushback on some of this big data that we have, right? We have all this big data, it's showing these correlations, but people want that cause and effect. You have Marco Buchesic at the ADA Health Policy Institute saying we need to have some larger randomized controlled trials. We need to really understand what the impact is on oral health and if we can improve it. I do not hear that from the physicians that we get to work with every day. What they come and say is they're frustrated. They want oral health to be part of the upper gastrointestinal system, and they do not want to wait for a disease to become a systemic problem. How can they get to it earlier? And we hear that over and over again. So to me, so I'll share with you, we have something called the More Care program, which is medical oral expanded care. I'll share a little bit more about that. But what I like to do is when we start working with a lot of these clinics, mostly in rural environments, is as we go through, I like to look at the clinical notes, because oral health to most of them, as these programs have come in, has become one more thing. How do I just fit this into my daily schedule? And what we work to do is to have them understand that they can tell us how it fits into their schedule. And we try to enlighten them that they're already doing a lot of the things that are here. And so what will happen if we are successful is I will start to see oral health as part of the review of systems. So when the GI system comes up, physicians and PAs tend to put it there. And nurse practitioners and nurses tend to put it in diet and nutrition. And that's when I know we got them. And it's not this thing I have to search for. And so I hope that as we try to prove something with this cause and effect, that we don't lose the centralized message, which is it's a disease of the upper gastrointestinal system. If we continue to go the way we're moving and trying to prove this, it does keep the mouth outside of the body. So I will move along. So I am from Pittsburgh, and I will tell you, I got to meet Fred Rogers twice, Mr. Rogers. He came to our school twice. Something special. I also got to meet Johnny Cash. Mr. Rogers and Johnny Cash are two people that you meet, and you are encompassed in their charisma. And he says often when you think you're at the beginning of something, you're at the beginning of something else. And as Allison and Steve Pollack have said, we want to move to person-centered care. If you do not think I do not have Mr. Rogers in the back of my mind saying, you're special and you're unique and what you do is important, every time I think about how we process through, I would tell you you're missing it, because it is that. So, Mr. Rogers. Sorry, I had to do a plug for Mr. Rogers, right? If you haven't seen the documentary, anybody seen that thing? Oh man, I cried on a plane. Person next to me is looking at me like I'm crazy. Like, what are you doing? They're looking and it's puppets on the screen, so I can't imagine what they're thinking, you know. But you know, it's kind of that process. And so the truth is everything we tend to think about in public health is in challenges and facilitators, right? We try to break that down to understand how we move that forward. And what the University of Montreal did was they actually looked from a global perspective, reviewed all of the literature, and came up with the question of what are the barriers in facilitators. And I'll share some of those with you. The barriers, I think we know most of them. I'll kind of highlight a few. Lack of political leadership and healthcare policies. So I'm going to evoke Dr. Marcia Brand here. Some of you know Dr. Brand. She's worked in the Senate with Senator Robert Byrd out of West Virginia for quite some time. And she has beaten it into me, over my head at times, that when the legislature thinks about oral health or dental care, they think about their hour and a half that they or their family go in to have the care. And so to them, it is not the same as the public health access issues that are in place. And so until we can start opening up that view, it does make it very difficult to move that forward. She always says, we don't amputate a toe every time something is infected on it, so why do we amputate the teeth? And that is how she's really been able to get some senators on board. Patients' oral health care needs. They decide what they want to consume. The truth is we have not empowered patients' people to be consumers. I know we often think of consumer as a dirty word, but in this case, one of our goals is how can I empower a person or a patient to spend as much time looking at their health as they do a flat screen TV before they buy it. Lack of effective interprofessional education, we'll talk about that a little bit. And in implementation challenges, health information technology, this is where I get to ask the question, how many of you are satisfied with your health information technology or electronic health record? 1 and 2. All right, so I'm going to have to ask you later because that makes 3. Now, I'm going to tell you the only other time I had somebody raise their hand, I said, great, what system? And they said, Dentrix. And I said, boy, that's interesting. I've never heard that before. And so we kind of moved along. Somebody came up to me afterwards, and you know what they told me? That was a Dentrix rep. So there you go. So I am going to also bring in Dr. Mark Deutschman. Dr. Deutschman has been imperative to the work that we have done. He's an associate dean at the University of Colorado. And he, at the University of Colorado, has a program where he meets with medical students to talk about the hidden curriculum, which is really, what are the things that the curriculum is making us do? Or what are those things that come up and bind us in inappropriate ways? And through problem-based learning, they actually try to move through this. And so I will also, just so you know, I consider Denver one of the capitals of interprofessional practice. Dr. Braun is here, Dr. Tawari is here. They were so influential in all the work that we've done, so I want to recognize that. But what he says is these are the things that he finds in the curriculum. Oral health means teeth. Teeth are a domain of dentistry. I know very little about teeth. Dentists know little about the rest of the body. Why are you, dentist, asking me about something related to teeth? And why is this patient coming to me about their mouth? And why can't I get a dentist to see this patient? Those are the things that come up as they're instructed. And so how do you overcome that from a medical standpoint is really what he has said is, well, we just recognize it. It's kind of like I have narcissistic tendencies. So the only way I can overcome that, Jack, you know what I'm talking about. You throw that out into the room, right? And you kind of let it sit out there, and that's really what they're doing. So I took a shot, no pun intended, for my anesthesia folks on the dental curriculum. Nothing on that one. That was a good joke, guys. Anyway, was it my timing, Avery? I'm sorry. I'll work on that a little bit. So overcoming the dental hidden curriculum. So these are the things that I see, especially as we go out and we try to get dentists to work together with medicine. That's what we do in our program. Not only do we put integration in to try to get them to do oral health, we hook them up with a network where they have referrals that can go back and forth. And as we go out and talk to dentists, these are the things that are glaring to me in the educational process. Oral health means dental care. Teeth are the domain of dentists, so at least we have medicine and dentistry agreeing on one thing. I do not see the need, a couple of you, I appreciate that. I'll get you $20 later for laughing. I do not see a need to know about treating systemic diseases. Physicians consider us as inferior doctors. Surgical intervention gets me to graduation and pays the bills after. Why is the patient coming to me about their health? And this is my favorite, because this comes up time and time again, and it is fundamental that if we do not fix this, there is no way that we will, if we do not have intra-professional practice, we will never have interprofessional practice. And that's team what team? I'm holding my own suction over here. I didn't see a hygienist or an assistant until I left dental school. And I see a lot of you shaking your heads. It's really interesting to me. We were in Denver. We got to visit an FQHC, and we were really talking about quality improvement and how you can initiate different things. And I got to meet the head of security, and he was telling me about a PDSA that he put forth because he was tired of there being a 2-hour wait with a line out the door. And so he went to the CEO and said, if you just move these 2 kiosks over to here, it will make for a better patient experience. And they did, and sure enough, the wait time went down to about 15 minutes. So I ask you in dentistry, could a front office person, could the person in security go and make a recommendation at the top and actually make a change from the bottom up? Dentistry is so traditional bottom down, or top down. So how do we fix that? And how do we get more team involvement? If they're not being exposed to working in a team and they're learning how to work by themselves with everything, How do we get them out of that process? So what are the facilitators? There is financial and technical support from governments, stakeholders, and nonprofits. Sometimes there's a lot more, sometimes there's not. Interprofessional education for non-dental providers has grown. If you look at Smiles for Life as a platform, I think we're up to, 40 or 50 organizations that now support that. Tens of thousands of people run through that and train on that. Judy Haber, whose name was here before, every nurse goes through NYU, goes through Smiles for Life. Collaborative process, perceived responsibility and role identification, understanding who, what, when, where, how, and why. We're seeing case management be a part as we look at high-risk patients, and the incremental approach, which I'll talk about a little bit later. The other thing that's a facilitator to me is increased consumerism. If you look in 2014, the ADA Health Policy Institute put out Growing Consumerism, and they're showing that patients are now looking at scorecards online. They're trying to do more shopping. And it was really interesting because if you looked, it grew exponentially as you went from baby boomer to Gen X to millennial. And so we're seeing a shift in how consumers interact, most likely because of Amazon or, you know, any of those. So, the best creative solutions don't come from finding good answers to the questions that are presented. They come from inventing new questions. So I'm going to introduce to you more care, medical oral expanded care. It was grown out of rural America, and I will tell you the story behind it. Before I took this position, was a rural dentist in South Carolina. There's so many cotton fields that when it was cotton picking season, you would have sworn it was snowing out. And the big city Yankees would keep coming to us with all of these platforms and say, hey, we're going to solve your integration problem. We have it all figured out. Here you go. Call me if you need anything. And it was just this list of things. Okay, here's step 1, and then here's step 20. And it just doesn't work because the variability within just our 7-county system didn't allow that to occur. And so one of the things that we wanted to do was really take a step back and not just force oral health, but let people tell us what they wanted. We wanted to hear how their system would operate around it, not how we could change their system to do what we were asking. So the first place you start is you say, okay, what's the environment and soil? I will thank you because when I looked, I did this just when I came in this morning. There are 11 of you who were part of the white paper and your organizations that help really solidify this and say, okay, here's the soil in which interprofessional practice can grow, how we can make networks. The networks for us is, do we have medicine, behavioral health, and dentistry working together with community support mechanisms? Forms a community network, because for us, if we can't get the community to want to be healthy, then there is no way we can get individuals. So these are those 5 pieces of soil: health information technology, which is still the bane of my existence; oral health proprietorship, which is ownership. The reason we chose the word proprietorship there is because we wanted to make sure that everybody owns it. It's like an ESOP company, right? Everybody buys in. It's the Green Bay Packers, and that's really what we're trying to establish. If they can do that with freaking football, how can we not do it with healthcare? Dental referral networks, which is actually the hardest thing for us to establish. Transitioning care models and that environment of improvement. The one thing that, and I'll lean on my medical colleagues, you call me out if you think I'm wrong, but what happened in medicine is they tried to Kentucky Fried Chicken the hell out of it. And what I mean by that is quality control became more important than quality improvement. And so it was really a process of, if you think about Kentucky Fried Chicken, the reason that I can buy extra crispy here in San Antonio, go to Tokyo and go to New York and it's all the same, is because you have to use their equipment. You have to use their process. You have to use their chicken and their spices. They've taken the variability out of it. And that's what we tried to do in medicine without giving the practices the ability to improve upon their system based on the variability of their populations. And so what an environment of improvement means is, do the individuals at the practice level interacting with the patients have the ability to change course that meets the needs of the people that they're serving. So what we ended up finding was all these things were necessary, but there were a couple of levers that we knew we were going to have to invest in and spend time in. And before we did that, we wanted to make sure that we had a national scope. So what we were seeing was only in the 40 interprofessional oral health networks that we formed. So with the Medical University of South Carolina, this is when I give a shout out to Dr. Amy Martin, who there is no way I could have grown the program without her, and is just as important to the success that we've had beyond reason. What we set to do was we said, okay, it looks like the main drivers are health information technology and dental referral networks. How can we find the early adopters and innovators to ask them if that's correct and get a national sample? So what I did is I went out on the road and talked to people such as you. For 1 year, I did a survey. We wanted to have a good cohort that we could consider early adopters. So this is what most journals required us to say, a motivated population. Now, I know there's some epidemiologists in the room and some researchers in the room. This is a prospective questionnaire-based survey. There are lots of limitations. What we were trying to determine is what we're seeing in the local system, is that widespread or not? Because if it's not, then we're doing something wrong, and the system is still functioning. So here's how the demographics worked out: about 60% dental, 40% medical, rural 43%, the other pretty close. Clinical care was 30%, we had leadership 13%. Support staff and frontline health workers were around 57%. What was interesting for me is a large portion of the audience was a lot of those frontline health workers that were coming to hear what we were doing with interprofessional practice. And I still think we're not really reaching out to them as much as we could. So here's the first thing we looked at was the dependability of coordination. What we meant by that was, how dependable do you think your referral network is from medical to dental, dental to medical? And dependability, it is subjective. Really what we were giving them as an instruction was, how sure are you the patient is going to be seen the way that you would want them to be seen? So completely subjective, but here's what we found. When we looked at those things that impacted it, business model came up. If they were part of an accountable care organization or something similar, they were more likely to have dependability. FQHCs were next, and then private practice. After that, dental service organizations, large group practices, things like that kind of dropped off. Satisfaction and ease of use of electronic health records, basically that was a big driver. And then the other thing that came up that we don't talk about enough when we talk about metrics is no-show rates. And really this was the first inkling that we got, that we did not want to go down the road of ad hoc measurement, which is how we feel it has happened so far. It's, okay, I want to fix this disease, I want their A1Cs under 9, and that's just how we're going to drive it. What we're really experimenting with is, okay, how does no-show rate affect that? How are they interrelated? And how do we count the right way to progress towards health? Then we looked at dependability of integration, which was, are they doing fluoride varnish? Are they doing risk assessments and self-management goals? And so we found that if they felt that there was more dependability of their health information technology, or was easier to use, they were 2.4 times more likely to administer fluoride varnish. Some of the things that are important to really drive this: embedded risk assessments and then ease of reporting and monitoring. And then the other piece is medical to dental referral capability. When they had what they felt was a dependable dental referral network, they were 4.5 times more likely to administer fluoride, do risk assessments and self-management goals. This is when we knew we were seeing that that was the case, and that if we could not establish a referral network for those clinics, everyone where that was not really set, we did not have success there. What medicine wants, and please, I know there's a lot of folks directly from that, is they want a dependable specialist. They think there's a disease in place. They see the disease, and just like they would refer to a cardiologist to help prevent surgery from happening, they want the same thing from oral health. So progress is impossible without change, and those who cannot change their minds cannot change anything. Now, you might think I'm sitting up here a little self-righteous and saying that to you. This sits right on my desk. Every time I pull my drawer out to get something, that's for me. So what I'm going to talk about is kind of how we are looking at this process now, after we've learned the things that we've learned. So I am going to ask you, I'll put this up there, just humor me, and I've never done this before. I will tell you, I met with Laura and Avery for about 5 minutes before, and I said, hey, do you think this is going to be a good idea? And they both said yes. So if this does not go over, it's those two right there, it's both their fault. So if you can, just humor me. Can you put an S, a P, and an O on a piece of paper, and then draw an upside down triangle for me? All right, thank you. I'm paying attention. Everybody doesn't do it, by the way. So what I have in front of you is what we call a person-centered pathway. And this is really how we started establishing our interprofessional oral health networks. It takes dental care teams, medical and behavioral health teams in the healthcare system in a community with community health support systems. And there's a multitude of them to actually make this work effectively. If the community, at least those that should be involved in the community, are not involved, then we have problems. One of the things I like to do going into a rural community is every rural community, if they have the economy to be able to support health, will have a Sheetz, they'll have a Dollar General, and they'll have a McDonald's. Did you guys know what the number one thing people do after they get their teeth cleaned? Get gas. You know the second thing they like to do? Go to McDonald's. Do you know one of the most popular things on the menu? Any hygienists in here? All right, you're gonna love this. You know those cherry pies they make? That's like one of the favorite things they get. But I'm saying this to say, don't always think it has to be people in medicine. Dollar General is actually interested because it draws people to them, right? If you're in a rural population center. So one of the things I would like to do is, hey, can you give me 3 more feet of oral health product in here? And what we'll do is we'll promote that so that people know. Because I would go in and Dollar General's, they would have counterfeit toothpaste that had no benefit whatsoever. And so how do you start educating them? Because there was no fluoride in the toothpaste anybody could buy. So things like that become very important when you're trying to actually accomplish these things. So we have these person-centered pathways. So on your drawing, if you can, right over here, can you put experience of care for me? Because it's that person, you got me already, don't you, Jack? Person-centered pathway is really the experience of care that we want. Now, I will point out over here and over here, that's where measurement comes in. You have to be able to measure both at the practice level and at the top level. We have a problem in the US because all of our measurement is sole proprietor based. There's a great article came out a couple months ago from Amy Rigault. She found there's 213 oral health measures being used globally. And she was able to divide them into 2 aspects, a European system and a US system. US system, very practice level based, European systems, very systems level based. I believe the sweet spot is somewhere in between. And trying to figure out how to get there is very difficult because it takes the ivory tower to reach out to the practices because they need to be accountable not to one another, but accountable with one another. And then the other piece that makes this all drive is money. Now, I do like to tell my team from time to time that we are in a capitalistic system. There's no way you can get around that. And if you want to change that, it's my opinion you're not going to change it through healthcare. You might want to go run for office, which is fine. We'll support you in any way we can. So you do have to make sure there's sustainability and viability in whatever system is in place. So I know that Dr. Mark Doherty is going to come up later and go into more detail. What I want to say here is that there's 4 categories that the HCP land have identified. And the way that we have started to progress through this is we do not see it as a shift from left to right yet. We see growth on the right side of the scale. And so in our design, we have to make sure that the practices that are working can live in a mixed payer system where they're understanding all 4 categories. Because from a viability and sustainability aspect, if you really want to make people healthy, you're going to have to do that within all 4 categories, probably for the next several years. So if you can, for me, if you can just put some money symbols right down here. Now, I am sharing this with you. This is the first time I've shared this in public anywhere. Please notice at the bottom of the left-hand corner is preliminary analysis. We put this together just for this meeting very quickly. It represents our More Care partners in Oregon. What we have been asked to do there is to develop a better outcome measure than what they have now. And I will tell you, it has been painstaking to figure out how we can do that in a profession that does not agree what a carious lesion is. I'll let that soak in. Some of you laughed, and yeah, I said it right out loud. So what we ended up doing was taking a step back, and we talked to our physicians, and I will tell you, they helped us immensely. Because they said the one thing they're most frustrated about is, I do not know if my patients are overtreated or undertreated. And how do I find that out? And I said, well, how do you do it with the cardiologist? How do you do it with the podiatrist? And they said, well, surgical intervention rate is very important to us. How many people go to the cardiologist have to go have the surgery done? How many people go to the podiatrist have to have an amputation? That lets us know what's going on. We know that in Oregon, where most of this data is coming out from, they're in a special, unique situation where the traditional revenue and cost centers are the complete opposite of the rest of us. And so we had to figure out, okay, how do we drive this? So what we did is we said we want to look at risk-stratified surgical intervention rates. And we want to be able to benchmark those and then move those forward. Then we said, okay, we got to put some cost around that. Because the one thing that they want to know is, where's the predictability? So if you think about value-based care, we are asking providers to take more risk. We're saying there's more risk with what you're doing. Our job is to find out how we can make it more predictable for those providers. And so what you'll see here is you'll see on the right-hand side, basically according to risk, what the costs are. And one thing we discovered was it wasn't important to know the total cost, kind of is, but not as important, as the range. Because the one thing that you want to do to add predictability is you want the range between the lowest cost and the highest cost to be as predictable as possible. And you can see here, we're looking at $500 of a range for our low and moderate risk patients, which is way too high. And so if we can't control for that, maybe it's the way the risk assessment does, maybe it was the way the intervention was done, who knows? But the way we are looking at it is how do we improve that range to make it less? And in doing so, add predictability into the system. So if you can, over here where the O is at, can you put population health or risk stratification? So when Annalise did the silo, which I have to tell you is freaking brilliant because it told me exactly who the audience was. And I saw research real big and I saw epidemiology real big. So I thought there would be some Donna Bedian fans in the audience. So if you were to fill in your triangle for me, the S is structure, the P is process, and the O is outcomes. And if you were to then turn your triangle the right side up, you will see that that is the triple aim. And that is how we are processing through. Now, I am noticing some of you have a bad look because you do not believe that Donna Bedian can help you because it is so freaking rigid. So that's where Anderson's behavioral theory comes in for us. And our driver of Anderson's behavioral theory is health information technology. That is how we're going to drive the behavior. Oh. And that, my friends, is a welcome to preventistry. Any questions? Yes, please. I only do this for the applause, so please.
So I would also like to remind everybody, since Dr. Boynes and Ms. Grainer provided a lot of information, all of the slides are available on the Colloquium website. So if you go to aidph.org/colloquium, you can find all of the slides there for download. So questions?
Good morning, and thank you for your presentation. I have two quick questions. The first one is around what the organization may be doing as far as looking at dental practice acts per state, and as it relates to this whole interdisciplinary care issue. I recently moved from Texas to Mississippi, and doing some of my preliminary assessment, one of the things that I noticed was that, of course, we have a lot of chronic disease, diabetes, cardiovascular disease, and I started looking at the Dental Practice Act and how they compared. And so in my preliminary assessment, when I compared Texas, for example, with Mississippi, Texas, you know, you have to put all of those vital signs down as it relates to your progress note. But that is not defined as such when I look at what's required for Mississippi. So what I'm talking about is really the infrastructure, and we're talking about helping to change and looking at systems that can assist with that. And so has there been any query to really look at those types of things from the state Practice Act perspective? Because if you've been taught, you know, to do it and it's not required that you include that in your note, you know, the accountability to the provider doing it. And so how do we move the needle to encourage our profession that dentists are co-managers of disease? And so that's my first question. And the second is around the EHR system and the inclusion of assessments that would assist a dental provider in being more connected with what's going on as it relates to those other variables. For example, behavior screenings that could be incorporated in an EHR system when a patient comes in, such that we have those preliminary things that we're working together on, that we can get clues about the social economics, all of those other issues that impact the care that we're trying to provide. So has anything been done on those two items?
No. Next. Well, I mean, that's the truth. I really could just answer it like that. The variation in our practice acts is fragmenting and stagnating our ability to work. We run into that everywhere. We end up flocking to places like Oregon and Colorado because their practice acts are more freeing. The one thing that we did do with this, because it was a rural, we started it in South Carolina, which I don't know if you're aware, but the legislator actually has a hold on the Practice Act because the organizations were fighting so much that they just said nobody can change the Practice Act for 5 years. So we did start it there and have success. And the reason that we had success kind of answers your second question. First, we do not have an electronic health record in dentistry. We have practice management software. So that is the biggest issue we have, because if somebody makes those changes, an administrator wants to know, do those changes work? And the only way to do that is through a billing apparatus, which gets us some information but doesn't allow us to actually impact care as much as we would like. What we have noticed is by bringing medicine more directly into oral health or dental care, there is an accountability piece. I can only say that we have a theory. We do look at data, but one of the things that has been interesting to me, and please, this is a theory, we're still working through it, and I would encourage you all to do the same to help. But what we find is we cannot say that when somebody has an oral health intervention or prevention on the medical side that people get better. But what we can say is that accountability between medicine and dentistry seems to have a healthy effect. And what we are theorizing is that minimally invasive restorations seem to decrease when medicine is able to evaluate the process. And so I think that answers some of your questions. Look, I've helped clinics in Sebastopol, Mississippi, and Jackson, and I tell you, Mississippi's a tough case. I commend you for going there, but that one's going to be a tough one. So I can't help you all the way. I can only give you that bit of information. Yep.
Questions or comments? Are you a Mississippi State or an Ole Miss fan? Yes! Go Bulldogs. Any other more relevant questions or comments? Okay, Dr. Boynes is going to be facilitating our discussion session. So he's going to, we're going to pull up some, you had a visualization, right?
Yep, they're getting.
And so, Dr. Boynes, would you like to sort of review your prompt and talk about what you'd like to facilitate?
Yes. It's coming. I can see them working.